Ranjiv Mathews. I'm a pediatric urologist at SIU School of Medicine. I work at St. John's Children's Hospital in Springfield, Illinois. And I'm here to talk about infections and bladder exstrophy children. And there are three time points in which children with bladder exstrophy have a greater potential to develop urinary tract infections. The first time is shortly after closure of the bladder. Urinary tract infections are possible. Typically, these are in infancy. Children have catheters in the bladder, stents in place, etc., right after surgery, which can cause contamination and urinary tract infections. These are typically fairly easily managed. Post-operatively, once the child is healed, there always will be reflux into both of the kidneys, and therefore we typically keep children with bladder exstrophy that have had initial closure on antibiotic prophylaxis to prevent urinary tract infections from developing in this rather susceptible group of children. Recurrent urinary tract infections in this group of children will require earlier performance of ureteral reimplantation, sometimes prior to bladder neck reconstruction. Another potential time point that children might be susceptible to urinary tract infections would be if they've had completion of their closure, including bladder neck reconstruction, but are now not able to empty their bladder for any reason. Those children are also at increased risk of having urinary tract infections. It is important to differentiate these from patients that are just have contamination, for example, if they're on intermittent catheterization for any reason. Again, some patients may need ongoing prophylaxis for management of these infections. The last group of patients that develop recurrent urinary tract infections in the context of bladder exstrophy are those children who have augmentation, cystoplasty, and continent urinary diversions performed and are using intermittent catheters. The issue with this typically is that these patients will always have a degree of contamination of their urine. However, they may be completely asymptomatic, and therefore treatment is typically not recommended for these children unless they become symptomatic. And that is typically with fever or other changes in smell of the urine, etc. It is important to differentiate this because otherwise these children get started on recurrent antibiotic therapy and can wind up with developing resistance to various bacteria. So this is critical. Treatment of infections in children with bladder exstrophy mimics that with any other urinary tract infection, in that they should be started typically on a 10-day course of antibiotics of a treatment dose. And they should be monitored to make sure that they have improvement in symptoms or reduction in fever. If these children do not have improvement in their symptomatology, repeat urine culture would be desirable. If a child does get symptomatic, ideally obtaining a good urine specimen, either using a catheterized approach or in the child who's able to void a good voided urine culture is critical. Use of bags, etc. in infants is really not recommended, as these children will contaminate those bags, and it's hard to tell whether these children just have contamination or a true urinary tract infection. But again, children with bladder exstrophy are at increased risk potentially of developing urinary tract infections. They should be monitored closely. If they are developing upper tract infections, they should have ongoing monitoring with ultrasonography. It is important to catch these early and treat them. Some of these children can get quite significantly ill. Long-term issues with having recurrent urinary tract infections include things like development of stones, especially in patients with augmentation cystoplasty and in patients who have stones in the context of augmentation cystoplasty. Removal of those stones is going to be essential to prevent persistence of infections, and some of these stones can actually hide bacteria that are difficult to get rid of. There we go.